Hello students, I am Dr. Rana, consultant gynecologist at Usha Bansal Nursing Home.
So the question is, a lady presents with history of recurrent pregnancy losses at 8 week, 11 week, at 8 week, 11 week and 22 weeks. Okay, at 8 week, 11 week and 22 weeks. She also had preeclampsia in the last pregnancy. In the last pregnancy there was history of preeclampsia, high in the BP. Cardiac activity of all the 3 pregnancies was normal. Which of the following is the most probable cause? Okay, so we need to tell the etiology of the abortions which was occurring in each pregnancy. Okay, clue is that they are occurring recurrent pregnancy loss, and there was a preeclampsia in the last pregnancy, a state of high BP, and number 3 clue is the cardiac activity. The starting of the pregnancy was normal in every pregnancy. Cardiac activity came in all the pregnancies. Okay, let us see what is the most probable cause. The options are syphilis, Apla syndrome, torch, gestational diabetes mellitus. So let's study about the abortion. First of all, what is abortion? Abortion is if the fetus delivers before its viability period, and in India that is 28 weeks. The fetus delivers or expires before its viability, that is around 28. In India the viability period for the fetus is 28 weeks. So if the fetus delivers before that, then it is not known as abortion, because mother cannot get that baby. Okay, so what is there is a MTP Act to who can abort the fetus, when the fetus is to be aborted. So for all that there is a MTP Act, Medical Termination Act, Medical Termination of Pregnancy Act, and that act has undergone amendment in the March 2021. Okay, as per that act, fetus can be aborted up till 24 weeks. Okay, fetus can be aborted up to 24 weeks. Let's see who all can abort the fetus. First of all is a gynecologist can abort the fetus. Number 2 is a doctor who is not a gynecologist but is a doctor and has got a 6-month training in the gynecology department. Okay, then a doctor who is a doctor, okay, and has done 25 MTPs under supervision of a trained gynecologist. All these 3 categories of the person, they can abort the fetus. Now, at what time the abortion can be done? Okay, in general it is 24 weeks as per amendment in the March 2021. But if there is contraceptive failure, then fetus can be aborted only up till 20 weeks. Okay, if the pregnancy is due to the contraception failure, then the fetus can be aborted up till 20 weeks only, not more than that. And if it is a patient is a rape victim, then the pregnancy can be aborted up till 24 weeks. Up till 24 weeks. And if the fetus has anomaly, due to that the fetus survival is impossible when the fetus will be delivered. So in that case there is no limit. But if that anomaly is not suitable for survival or not, will be decided by the board that consists of 4 members. Okay, one is of course the gynecologist, second member will be the pediatrician, and third will be the radiologist, and fourth member will be from the state. Okay, if that board says that this anomaly is not suitable for the survival of this fetus, then only that fetus will be aborted, and there is no limit. Whenever the parents want, they can abort that fetus, but only if the permission is get by the board. Okay, now single doctor opinion is needed up till 20 weeks, and after from 22 to 24 weeks 2 doctor opinion is needed. From 22 to 24 weeks 2 doctor opinion is needed. Now let's discuss something about the etiology. Basically that was our question. If the abortions are occurring in the first trimester, then most common is the chromosomal anomalies. And among the chromosomal anomaly, the most common anomaly is trisomy 16, second most common is trisomy 18, and third most common is that we all know trisomy 21, the Down syndrome. Okay, the most common anomaly responsible for the abortion in the first trimester is trisomy. Mind it, I am not telling triploidy, it is trisomy 16. Okay, and if the abortions are occur in the second trimester, then mostly the cause is the anatomical defect. It can be a separate uterus, it can be a bicornuate uterus, or it can be an incompetent os. Okay, what is separate uterus? You all know that Mullerian ducts fuse laterally and then the septa resolves. If that septa doesn't resolve, in the endometrial cavity there is a septa in between and it can lead to abortion. Not always, but sometimes it can lead to abortion. So if a patient with separate uterus have a history of recurrent pregnancy losses, then that patient should undergo septal resection, which is a treatment. Okay, so always mind it that it is not necessary. I have delivered a lot of patients with septum very normally. Not always the septate uterus is responsible for the abortion. Now what is bicornuate uterus? We discussed now only that the two Mullerian ducts fuse laterally. Now if the fusion is partial, they have fused from the lower side and they have not fused from the upper side. Okay, then there will be two cavities in the uterus, and two cavities are not separated by the septa, but they are separated by the uterine walls, because the Mullerian ducts have not fused in the upper part. So in the upper part of the uterus there will be two uterine cavities which are surrounded by uterine walls, endometrium, myometrium and serosa. And if that type of uterus is causing recurrent pregnancy losses, then the treatment is metroplasty. Metro is the word used for uterus and plastic is uterus surgeries, metroplasty. And only if, again like septate uterus, if that uterus is causing recurrent pregnancy loss, otherwise no surgery. Okay. Third is the incompetent os. What is incompetent os? During the pregnancy, the cervix during the delivery, the cervix gets effaced. If the cervix is short in size, in length, normal the length of the cervix is 4 centimeter. If the length is short, then that cervix will easily get effaced and it will lead to preterm labor pain. If it's quite more short, then even the fetus can deliver in the second trimester. So incompetent os is the os in which the cervical length is short, less than 2.5 centimeter, and the treatment is that we are going to support the cervix by a encirclage suture, and encirclage is done can be done any time if the on ultrasound the short cervix is diagnosed after 12 weeks. Okay, so most common suture which we apply in encirclage is McDonald suture. What is it? Let's suppose this is the cervix. We apply sutures like this and then we tighten it, purse like a purse string. Okay, this is known as McDonald sutures or purse string sutures. What are the warm stitch? In the warm stitch, if this is a cervix, we apply one suture here, then we give a knot here, and then we apply a suture here, and then we give a knot here. Warm stitch at 90 degree, a transverse sutures and the vertical sutures at the 90 degree. What is shortcut stitch? Imagine if there is no length in the cervix to apply the suture, then one needs to reflect the bladder and then apply the suture. That is known as a shortcut stitch. Okay, these stitches can be applied vaginally, they can also be applied abdominally, and they can also be applied laparoscopically. Let's see about some maternal causes. Maternal problems that can lead to abortion. One is a thrombophilia. What is thrombophilia? Body has increased tendency to form thrombus, because thrombus is formed, so in the placenta also the thrombus is formed. As already discussed before, the pregnancy is the stage of a hypercoagulability. Now the thrombus formation increases. In placenta also the thrombus forms, and due to the thrombus formation in the placenta, there is increase in the BP and there is decrease in the placental perfusion, leading to the abortion. So what are factors that leads to the increased thrombus formation is antithrombin deficiency, protein C and S deficiency. The other diseases which start from T, that can mother diseases which start with T, have been listed in the line. One is thrombophilia, another is the thyroid diseases, torch and TB. So all these 4 diseases start with the alphabet T, so that you can easily learn. The another 2 diseases which can lead to maternal abortion is SLE and syphilis. Okay. Now is APLA syndrome. What is APLA? Lupus anticoagulants antibodies are formed, anti-cardiolipin antibodies are formed, anti-beta 2 glycoprotein antibody are formed, again which leads to less inadequate placental perfusion like the thrombophilia, and there is increase in BP, and there is placental perfusion and abortion. Celiac diseases, allergy to the gluten, and diabetes mellitus. Okay, what is recurrent pregnancy loss? If 3 or more than 3, if 3 or more than 3 abortions are occurring consequently, ठीक है, एक के बाद एक, consequently is एक के बाद एक, if more than 3 or more than 3 abortions are occurring, that is known as a recurrent pregnancy loss. Okay, torch can never cause recurrent pregnancy loss. Okay, because once the infection is there, then immunoglobulin G is formed in the body, and then that cannot cause recurrent abortions. Most common cause of recurrent abortion is chromosomal, and second most common cause is APLA and thrombophilia. So persistent reasons can only cause recurrent abortions. So now the answer to the question is here, syphilis infections cannot cause recurrent abortions. Torch it cannot cause, APLA and GDM can cause, and in gestational diabetes mellitus, usually the abortion, if it occurs, it is around 32 weeks around. So and the hint is also given that the patient also had a history of preeclampsia, because in the APLA increased coagulability is there, which lead to decreased placental perfusion and increase in the BP. Decreased placental perfusions lead to the death of the fetus. So the answer to this question is antiphospholipid antibody syndrome. So let's discuss some terms more about the abortion. What is threatened abortion? Abortion that is only in a threatened stage. We can prevent that abortion. Okay, we can prevent that abortion. In that case, the findings will be the cervical os will be closed, because once the cervical os opens, then we cannot prevent that abortion. And the gestational size, the uterine size is equal to the period of gestation. Only some spotting has occurred. Patient gives us some only a thread is there, and that thread can be given. That thread can be removed by giving the patient progesterone. Okay, so treatment of the threatened abortion is progesterone. What is inevitable abortion? Abortion that cannot be prevented. Threatened was abortion that can be prevented, and inevitable abortion is abortion that cannot be prevented. In this, os has opened and products are there in the bulging in the cervix. So now then it is impossible to again put that products in the uterus and do implantation. So inevitable abortion is, what are the signs in the inevitable abortion? The os is open and products are felt in the cervix. What is, and they are bulging in the cervix. So this cannot be prevented. So we can do the dilatation curettage and we can aid in the abortion. What is incomplete abortion? Some products the patient has passed vaginally, some product of conception, and some are there left in the uterus. Now there will be bleeding. Uterus will try to expel the remaining products. Okay, nature will try to expel, so the patient will bleed and the os will open. So what are the signs in the incomplete abortion? Os will be open, bleeding will be present, and patient will give history that something has passed out from the uterus, some mass has passed out from the uterus. What is complete abortion? If everything is evacuated from the uterus naturally or by the drugs, then that is known as complete abortion. In the case of the complete abortion, the os will be closed. Okay, there will be no bleeding and patient will give a history of that something has passed from the uterus. Okay, missed abortion. What is missed abortion? If patient is once the cardiac activity has come in the fetus and then the cardiac activity has gone and fetus has died, then that is a case of missed abortion. In our question, these all were the cases of the missed abortion. In these were the cases of the missed abortion because cardiac activity has come, right? So what is blighted ovum and an embryonic pregnancy? A embryo in which only and only gestational sac is formed. No fetal pole, no embryo, no yolk sac, only and only gestational sac, and empty zygote is a an empty gestational sac is an embryonic pregnancy. A sac in which there is no embryo is known as either blighted ovum or an embryonic pregnancy. How we can abort the fetus? Okay, how we can abort the fetus? It can be aborted by medicines. Okay, by medicines 7 week to 9 week. 7 week to 9 week. The tablet mifepristone is given to that patient 200 mg. What is the function of the mifepristone? How it acts? It is an anti-progestin. Mifepristone is a anti-progestin. Anti-progestin is progesterone is responsible for maintaining the pregnancy. Anti-progestin is it will not able to maintain the pregnancy, so fetus will get embryo will get killed. Okay, embryo will kill by the mifepristone, and its dose is tablet 200 mg mifepristone oral. Okay, and up till we can give this drugs in up till 7 week to 9 week of the pregnancy. Tablet misoprost 800 microgram. Misoprost is what? It is a prostaglandin E1. Question do come with this name, prostaglandin E1. Yes, so you should know the both name, misoprost and prostaglandin E1, and this is given 800 microgram oral 48 hours after the mifepristone, because mifepristone takes the time to kill the fetus, takes the time to act. So this tablet is given after 48 hours of the tablet mifepristone, and its dose is 800 microgram. It can be given oral, it can be given sublingual, it can be given vaginally. Best is vaginal method. Okay, and what is the function of this prostaglandin? This prostaglandin E1 misoprost, it expels the fetus. It expels the fetus out of the uterus and aids in abortion. Okay, mifepristone kills the fetus, and prostaglandin E1 misoprost, it expels the fetus out of the uterus, and the uterine cavities are free of pregnancy. Now, if the patient does not want to take drugs, is there any surgery which can help in abortion? Yes, manual vacuum aspiration is done up till 6 weeks by manual evacuation syringe, MVS syringe. Suction and evacuation is a procedure which we can do up till 10 weeks, and dilatation and curettage can be done up to 12 weeks. What is dilatation and curettage? Dilatation, we do it dilatation of the cervix because the pregnancy size has increased up to 12 weeks. So to remove a large fetus, we have to dilate the cervix, we have to open the cervix, and that is done by a dilator, which are a rod like structures we put in the cervix, and we dilate the cervix, and then the curate is done to expel all the products of the uterus. Okay, though the dinoprostone and carboprost has not to do large with the abortion, but still you should know that prostaglandin E1 was misoprost, prostaglandin E2 name is dinoprostone, and it comes in the market as a vaginal gel, and prostaglandin F2 alpha is carboprost. Prostaglandin F2 alpha is carboprost, and it comes in the market in the injection form, and it is to be given only IM, because IV cause sudden hypertension which can be hazard to the patient. Okay, so this was all about the abortion. Thank you. Question. Now the last question, an important topic, placenta was left out, so I am adding this topic in the last question itself. Let's see the question. This question is asked in a different form in the NEET PG 2022. I have just changed the question to get your orientation toward the placenta. The following procedure is being done on 25 years old lady in labor. Okay, the procedure is done. Basically, what is this procedure? This is a controlled cord traction to remove the placenta. Okay, the cord gets torn, cords get torn. What type of placenta it could be? Succenturata, circumvallate, battledore, or bilobed. So let's study what is all this. So basically the placenta is a feto-maternal unit. Some part of it is formed by the fetus and some part of it is formed by the maternal mother. The fetal trophoblast, they invades the endometrium. Okay, which part of the fetus makes the placenta? Trophoblast. Okay, And which part of the mother makes the placenta? Endometrium. Okay, now that trophoblast, it invades the endometrium. They break down the endometrium blood vessels. Which blood vessels supply the endometrium? Spiral arteries. So they break the blood vessels and they change them into lacunae, large cavity filled spaces, and then this fetal trophoblast, they form villi around that lacunae. Okay, so which part of the trophoblast is responsible for making the placenta? Not the whole trophoblast, chorion frondosum. And which part of the endometrium is responsible for making the placenta? Endometrium basalis. Okay, the umbilical cord, it has two artery and one vein. Basically it was having two arteries and two vein, but the right umbilical vein, two arteries and two vein, which are known as umbilical arteries, right and left umbilical artery and right and left umbilical vein. So basically it has two veins and two arteries, but the right umbilical vein gets obliterated as the pregnancy progresses and only the left umbilical vein is left. So as a result, two arteries and the left umbilical vein. Okay, now what does this umbilical arteries do? They form the fetus, this umbilical artery, they are known as arteries, but they carry the deoxygenated blood from the fetus. Then the oxygenation occurs in the placenta, and then the umbilical veins, they carry the oxygenated blood back into the placenta. Into the fetus. Okay, single umbilical artery, if it is there, we only now study there are two arteries and one vein, vein is left. So if there is a one umbilical artery, then it is a problem. Okay, what does it indicates? If there is a single artery, what does it indicates? It indicates that there is a increased risk of congenital malformation in the fetus. The fetus need to be evaluated again and again. Increased risk of congenital malformation in the fetus. It is seen in patient with obstetric diseases. Okay, if the patient, it means the patient mother is having itself obstetric diseases, and it is a rare condition, not a very common. Less than 1% of the cases only have single umbilical artery, but single umbilical artery gives us two indication that mother can have any obstetric diseases or the fetus have a congenital malformation, so they needs to be ruled out. Now, what are the different types of placenta that the question has asked? What is a battledore placenta? Now, this is placenta in this picture is normal. The umbilical cord gets inserted in the placenta at the center. This is normal, and this is a battledore placenta. What is a battledore placenta? Okay, the cord has inserted in the margin, not in the center. It has inserted in the margin. Okay, attached to the side of the placenta rather than to the center. Now what happens? Now after the delivery, when we try to give control contraction to expel that placenta, because it is attached to the margin, so the pull breaks the placenta. Okay, and the cord gets torn, and then we need to manually remove the placenta, and that was our question. The cord gets torn during the control contraction. So what type of placenta it can be? The answer to this is battledore placenta. Let's see the other placenta. What is accenturata placenta? Rather than one lobe, rather than one portion of the placenta, there is also another portion of another portion, and that portion is connected by leash of vessels. A small lobe of placenta is also present along with the main placenta, and that is connected by the vessels. What complication it can give? When we remove that placenta, that small lobe that can stay in the uterus, and it can lead to secondary PPH. And what we can do if there is secondary PPH due to that small lobe of the placenta? Curettage. Okay, so in the battledore placenta, the treatment was manual removal of the placenta, and in this case the treatment was curettage. Okay, so this is another placenta, filamentous placenta. So now you should know that umbilical cord, it inserts in the center of the placenta, and within the placenta then these three components, two arteries and one vein, this separates. Now if this separation occurs before, see, this separation is occurring before, Okay, then that placenta is known as the filamentous cord or filamentous placenta. So vessels are splitting much before into arteries and vein. Now when it can be a problem, usually it is not a problem, okay, but it can be a problem if, see, this is a uterus and this is the placenta, and before here they have, this is a fetus, okay. So the vessels are splitting much before into arteries and vein, and when this, and here this fetus, when it puts the pressure, let me draw it properly. Usually it doesn't cause the problem, but the condition in which this is the placenta and this is the cord, and ये पहले ही split हो गई है, and this is the okay. So now यहाँ पे it has splitted before only, okay. So this is the filamentous cord. Now if that cord is in the lower part, that splitted cord, filamentous cord is in the lower part. If it is in the upper part, it will cause no problem. And if that cord is in the lower part and this fetal head will put pressure on that cord, then that cord will, that vessels, not cord, vessels, that vessels will tear and large amount of bleeding will there. When the splitting is present in the lower segment of the uterus and the baby is above this cord, only in that condition the cord will break or the vessels will break and the fetus will bleed, and fetus has very less amount of blood, okay. It is not like the mother bleeding. Mother has 6.5 liters of the blood, but fetus has very less blood. A small bleeding is very fatal for the fetus. It can lead to fetal demise, and so it causes, okay. So vasa previa is not the cord presentation, okay. Here vasa previa is vessels are there in the lower segment, not the cord. Filamentous, in the filamentous vasa previa vessels are there. So vasa previa, vessels at os, possible only in the filamentous cord, not in the normal cord. Cord presentation, normal cord is there at the os, okay. What is APT test or alkaline denaturation test? In this blood, if blood is coming out of the vagina in the case of the vasa previa or the torn umbilical vessels, then we need to know whether it is fetal blood or maternal blood. We will put that blood and then put that alkaline. If the bloods get denatured, then blood gets denatured, then it is a maternal blood, and if it resists denaturation, then it is the fetal blood. And what is the alkaline agent we put? Sodium hydroxide. Circumvallate placenta. What is circumvallate placenta? In the circumvallate placenta, this is the placenta. It has two plates, amniotic plate and below is the chorionic plate. In the surface of the placenta which is toward the fetus is known as amniotic plate, and surface of the placenta which is toward the mother is known as the chorionic plate. Amniotic plate is more than the chorionic plate, so there is folding of membrane. Can you see this? There is folding of the membranes, okay, and due to this folding of the membranes, it is said that there is inadequate perfusion and it can lead to the IUGR, okay. So that covers almost all the important topics of the FMG. Hope to see you again. Best of luck for your exams. Thank you.
I hope you like this video. Please subscribe my channel, share this video to all the FMG aspirants so that they too can get benefited from this. Thank you.